all these restaurants.
Calling the meeting on the Committee of Health and Human Service Policy to order. We do not have a quorum, but we do have a chief author of a bill before us. So we're going to start there. So the first bill we have up is House File 147, Representative Huot. Welcome to the committee. The chair moves that House File 147 be recommended for re-referral to the Committee on Ways and Means. Members, we have the bill before the committee. Representative Huot, I understand you have an author's amendment.
Madam Chair, I do, and I would like to have someone move that for me.
Okay, the chair will entertain. Oh, so since we do not have a quorum, we're going to hold on to that amendment until we have a quorum. You can explain the amendment to us and then present your bill to us.
Madam Chair and committee members, this is my second time before this committee on this bill. We did have some work we had to do on the bill, and I believe that has been done now. The amendment simply takes out emergency medical technician and gets the bill in the format that I would like it in, and actually you should have received a letter from the MSRB saying they now agree with the bill too.
Thank you. Please proceed.
So basically that's my bill.
Oh, that's the bill.
We presented, we had testifiers.
You've heard it before.
And you've heard it before, and hopefully when you get a quorum you can act on it.
Absolutely. So, thank you. We're going to set it aside until we get quorum. Representative Pinto.
Thank you, Madam Chair. Am I okay? And I think we'll need to have the bill first moved when we get the quorum too. So yeah, okay. Thank you, Madam Chair.
Okay. So we're just going to lay it over, stay around, and we're going to move to the next bill.
Enjoy the donut holes.
You got donuts? Pass the donut.
I wanted to keep you sweet. I know I brought them last time.
Representative Pearson? Representative Pearson, do you have a question?
This is about the donuts? That's why I'm getting yelled
Yes.
at? Calm down, Albright. Sorry. So did you ask for discussion on the bill? I mean, we can discuss the bill further.
Sure, if you have a question, yes,
I
go
just-
ahead. Representative Pearson?
I'm literally doing the markup now, so.
Okay.
Go ahead, Tom. That's okay. Here's your donut. Yeah.
I'll read.
Chris has got his coffee. I got my donut. You and me, buddy.
So Representative Pearson, what we're going to do is come back when we bring Representative Huot back, and by then your markups should be ready to go. Okay. So thank you. So we're going to move on to House File 1875. Representative Wazlawik. Okay, since we do not have a quorum, we cannot move the bill yet. You can talk to the A1 author's amendment and then present your bill.
Sure. Thank you, Madam Chair. So we do have an A1 author's amendment, and let me just find it here. It essentially makes a tweak to the subdivision title and then inserts the $500,000 appropriation on page 2, line 7.
All right, thank you. Proceed with your bill.
Thank you, Madam Chair. Chair Moran and members of the committee, I am pleased to introduce House File 1875, which would support a pilot project that the Center for Victims of Torture, or CVT, would conduct in partnership with the Department of Human Services. With me today are Pete Dross, CVT's Director of External Relations, and Allison Beckman, licensed clinical social worker and CVT's Senior Clinician for External Relations. We are fortunate here in Minnesota to be the home of CVT, which is the world's largest torture survivor rehabilitation program. It's an important international institution that for nearly 35 years has helped rebuild the lives of Minnesotans who are here as refugees, asylum seekers, asylees, and permanent residents, and who want nothing more than to overcome the legacy of torture and support themselves and their families. Legislation before you would expand a co-located behavioral health program to 3 new sites in Minnesota. It has 3 primary components, which I'll briefly describe. First, it would appropriate $1 million to CVT to support a 2-year planning and implementation period in which CVT would establish 3 new project sites, likely in St. Cloud, Minneapolis, and a city in southern Minnesota, probably Rochester. Second, it would establish the adult mental health targeted case management reimbursement rate of $695 per client per month to be paid by DHS, a level that will make this expansion self-sustaining without further legislative appropriations. Third, in a provision requested by DHS, legislation would appropriate $500,000 to CVT to work with DHS to determine if the tool that CVT has developed to measure social functioning can be adapted to work with a broader medical assistance population. I thank the committee for your consideration and would turn it over to my testifiers.
And before our testifiers begin, I would like to move House File 1875. A quorum is present, and so I would like to move House File 1875 to be recommended for re-referral to the Committee on Ways and Means. We have, I would also like to move the A1 Authors Amendments. All in favor? Say aye. All opposed? The motion prevails and the amendment is adopted. Okay. Also, while I have this moment, I would also like to make a motion to approve the minutes for Wednesday, March the 13th. Representative Fisher moves approval of the minutes for March the 13th. Any discussion? Hearing none, those in favor say aye. Aye. Those opposed? The motion prevails and the minutes for March the 13th are approved. Okay. And so, to the testifiers, before we move forward, and Mrs. Hawkins would like to speak about the amendment.
Madam Chair and members, I just have 2 technical fixes to this amendment. So on page 1, line 14, delete Minnesota statutes, comma. And page 1, line 16, delete Minnesota statutes, comma. Those references aren't necessary because this is coded language. That's it.
Okay? Thank you so much. To the testifiers, please introduce yourself. Welcome to the committee. Please introduce yourself for the record, who you're with, and proceed with your testimony.
Thank you, Madam Chair, members of the committee. My name is Pete Droz. I'm Director of External Relations at the Center for Victims of Torture. Survivors of torture and severe war-related traumas leave lasting physical and psychological wounds. Chronic pain in muscles and joints from being bound or hung or confined to small spaces like cages. Balance and mobility problems, often from being beaten on the soles of the feet. Sleep disorders, including sleeplessness and intense nightmares in which the torturers revisit the survivors night after night. Severe anxiety, deep depression, frequent thoughts of suicide. Thousands of Minnesotans suffer from these symptoms, often leaving them unable to work, care for themselves and their families, and function independently in the world. CVT heals the wounds, rebuilds the lives, and restores the hope of these survivors. We work with the most severely affected, people who are highly symptomatic and unable to function. Though we know our work is effective through our own measurements and through our own observations, for the past 5 years, we've tested our model against the care services available at 2 high-quality primary care clinics that were our partners in this project. The Health East Roselawn Clinic and the University of Minnesota Physicians Bethesda Medicine Clinic. My colleague, Allie Beckman, will briefly describe the study and the results, which form the basis of this legislation and the appropriations request.
Thank you, Madam
Thank you so much
Chair.
for your testimony. Please
Okay.
introduce yourself for the record.
Yep,
and
thank you,
proceed.
Madam Chair and members of the committee. My name is Allie Beckman. With our partners, we conducted a randomized control trial, the most rigorous scientific study possible. What we did is we enrolled over 200 Karen refugees from Burma in the study, all of whom were suffering with major depression. And then we randomly assigned them to a treatment as usual group or a control group or the CBT intervention group. Those in the treatment as usual group received services that the clinics normally offered, primary care and an occasional referral for other specialized services. Those in the CBT intervention group received standard primary care services plus weekly psychotherapy and adult mental health targeted case management provided by us, provided by CBT. We measured 4 psychological problem areas, including anxiety, depression, PTSD, and somatic pain. We used the Hopkins Symptom Checklist, the FOA scale, and a measure we developed internally for somatic pain. And we also measured 6 domains of functionality. We looked at basic needs, stability, employment, social support, adjustment, and community engagement. And this, again, was a special 37 questionnaire measurement tool that we designed to look at functionality and what does it mean for a refugee to be functioning well. We measured these domains at intake, 3, 6, and 12 months. And in each of the 4 psychological symptom areas and each of the 6 functionality areas, the CBT intervention group posted superior results when compared to that control group. We've been able to show many of you privately the charts and graphs. We can't do a handout because this data is currently out for publication. But for the control group overall, there was little change over time. For the CBT intervention group, the psychological symptoms went way down. And for social functioning, they went way up. The differences, according to our researchers, were not only statistically significant, but also most of the differences had a really large effect size, meaning that the magnitude of the difference was big. We would be grateful for the opportunity to replicate these extraordinary results at 3 new project sites in Minnesota. We finished the research study at those 2 clinics, and they've asked us to stay on, so now we just have permanent programming there, and we'd like to grow to 3 other places. We'd be pleased to answer any questions you have. Thank you.
Okay. Representative Fisher.
Thank you, Madam Chair, and thank you to Representative Wazlawik for bringing the bill forward. It sounds like some very good work. I did have a chance to talk to the testifiers before, and one of the things I just want to follow up on is one of the things that it seems is you folks are doing some really great work in terms of helping people heal from their trauma. I was wondering, as you're continuing this work, how much of that will be applicable that can be replicated and carried out, not just only to victims of torture, but to those in, like, the communities where I work in North Minneapolis, where you've got severe gun violence and other traumas like that. How much of this can be then carried over into those communities also?
Well, one of the pieces of this legislation.
To Mrs. Beckman.
Oh,
Please proceed.
Madam Chair and Representative Fisher, thank you for that question. One of the wonderful pieces of this legislation is that we're taking this social functioning measure that we designed, this 37 item measure, and we would be working with DHS to see if it is adaptable for other populations. They are interested in seeing if could it work for vets or homeless populations or other vulnerable people. So yes, thank you.
Representative Pinto.
Thank you, Madam Chair, and I just want to take this opportunity to note a little bit of Minnesota pride here, in case folks aren't aware that we really are a hotbed of human rights work around so right in the middle of North America, Center for Victims of Torture, the Advocates for Human Rights, and a number of other organizations, a really worldwide leader in this work. So thank you for your work, and I just want to make sure we're all aware of yet another point of Minnesota pride. Thank you, Madam Chair.
Thank you. We had a little technical issue we need to reconsider. So what I need to do is reconsider the motion of the A1 amendment. We need to amend the A1 amendment with the changes that Mrs. Clark-Fish discussed, and I would like her to just explain those once again to us, what those changes was to the A1 amendment. So I want to move to reconsider the A1 amendment. All in favor?
Aye.
All opposed? Motion passed. Mrs. Clark-Fish.
Madam Chair and members, the amendments to the amendment are page 1, line 14, delete Minnesota statutes, comma, and page 1, line 16, delete Minnesota statutes, comma.
So the oral amendment is to delete Minnesota statute, comma, in line 114, in line 1.16 to delete Minnesota statute, comma. Thank you. All in favor? Representative Pinto.
Thank you, Madam Chair. I guess as long as you're at it, you probably want to remove the commas on lines 1.15 and 1.16 after where it's references Chapter 256B and Section 245.4711, because there's no need for the second comma. Just as long as we're cleaning this up, as long as we're cleaning it up, might as well do that. But maybe Ms. Clark disagrees, though.
Madam Chair and Representative Pinto, it's a drafting convention to usually have a comma after a chapter or statutory citation. So I guess I would be inclined to leave those in, even though it might not be a usual writing convention.
Okay, so it would stay as an amendment, as amended. All in favor of the motion to amend the amendment, say aye.
Aye.
All opposed? The motion prevails to amend the amendment, as amended. And now I'd like to move a motion to adopt the A1 amendment as amended. All in favor, say aye.
Aye.
All opposed? The motion prevails to adopt the A1 amendment as amended. So, is there anyone else in the audience who would like to testify on 1875? Any discussion from members? Representative Albright.
Thank you, Madam Chair. Either to the author or to the testifiers, I note that you've done this work in the past and you're asking for 3 more sites. So can you tell me a little bit about the number of people that you intend or what each site would be able to facilitate a treatment plan for? And I note that your organization is worldwide. Now, obviously, sometimes, the opportunity may exist to utilize these dollars in other places other than the state of Minnesota. So I'm just wondering how this committee would find comfort in knowing that those dollars not expended outside of the state of Minnesota.
Mr. Ross?
Thank you, Madam Chair. Thank you, Representative Albright. 2 issues there. I mean, one, we will work with the Department of Human Services on an approved budget for both the 2-year scale-up to identify the sites and get them up and running. And we've submitted a budget documenting those expenses. Similarly, on the third component with the appropriation to adapt the functionality tool, we've also submitted a budget for that, and we'll work with the department on it. You also, of course, have our personal and professional assurances that these funds will be restricted to the work in Minnesota. And, of course, our financial statements are audited, and we can provide a documentation of all expenses on this project. In terms of the number of survivors, as I noted in my testimony, we work with the people who are most highly affected, the most difficult cases. Each of these project sites will serve about 52 individual survivors, the most highly affected. So there will be 2 therapists, 2 case managers. Each case manager will have a client load of 26.
Just to follow up, Madam Chair.
Representative Albright.
So how does your model compare or contrast with other models that focus on the same objective with a client base like you're describing? What's the compare contrast? What makes yours different and unique?
Mr. Ross. Mrs. Beckman?
Madam Chair, Representative Albright, I would say one of the ways in which our model is a bit different is that it is not a 10-session cognitive behavioral, you're in, you're out model. Our individual survivors have been so hurt at the hands of other human beings that one of the biggest things that needs to happen is people need to figure out how to trust folks again. It takes a long time. On average, at one of the sites where we see clients are with us for about 1.5 years. And that's about the time it takes for people to start trusting other humans again, to start to heal. There's many stages to healing as well. We found with our refugee population that we have to start with the basics, safety and stabilization. Do people have a place to live? Do they have food? Is where they're living safe? Do they feel safe in their bodies? With nightmares, people aren't sleeping. We work on that first. Second phase would be working through the trauma experience. This requires a great deal of trust and also stabilization to already be in place. Finally, we focus on reconnecting people with the community. They can't stay with us forever. The demand is big. We have a long waiting list. So we work to help survivors find a sense of purpose and meaning and reconnect in the community.
Representative Albright.
So you mentioned the word refugee. And I'm just wondering, Representative Moran and I share a passion for children, particularly as they suffer at the hands of their caregivers or someone that is overseeing their care, if you will. And I'm just wondering if this type of treatment extends to them as well.
Mrs. Beckman.
Madam Chair, Representative Albright, that's a great question. We started our work at this beautiful Victorian house in St. Paul, and over 85% of our clients were asylum seekers. Asylum seekers usually come by themselves as adults, and then if they obtain asylum, the children come later. So our expertise was really with the adults. When we started this project, it was exclusively with a refugee population, and we found that the children came into the room, and we had to work with the whole family. It's caused us to think about our treatment model differently. We're becoming much more interactive with schools. We're considering, should we perhaps do children's case management? Because when an adult is not able to fully attune to their child, often because of the traumatic experiences they've lived through, the children really suffer. And so, yes, we have been figuring out that we need to work with the whole refugee family.
Thank you, Madam Chair.
Thank you. Representative Edison.
Thank you, Madam Chair. To Representative your name is very challenging to say, Wazlawik. With regards to, and I may have missed it, Representative Albright asked a question because I want to know about the data. So in terms of, can you provide that to our committee maybe after this, just so that we have some numbers in terms of how many populations you're serving, what it looks like after with discharge, things like that. I would love to know that. The other thing that I'm curious. So for torture, can you give me some examples of what you mean by that? Because background as a therapist, I worked with a lot of people with trauma now, but I'm curious, like the defining characteristic of a change there. So if you could give me some examples, that would be helpful.
Ms. Beckman or?
Sure. Madam Chair, Representative Edelson. So to your first question, in terms of the data, I literally have it right here. I don't know if I can, I can't leave it with you because of the issue of it out for publication, but if I can show it to you, is that?
Sure.
Okay.
That would be
You
helpful.
can hand it to the page. The page will come and get that from you.
We might want to check
No?
legal on that.
Okay, why don't you just leave, is there some way you can just send it to us electronically? We want to stay focused here on what's in front of us. And we will make sure members get a copy of that.
Yeah, unfortunately, we can't distribute it in any, apparently with research publications, if you've publicized anything in any sort of way, it may bar you from
It may be helpful
publishing it.
just to check in with Representative Edison later on. Yeah.
That would be great. In terms of your question about what do we mean by torture, so torture, we use the United States definition of torture and also the UN definition of torture, which relates to an individual being targeted because of one of a number of things, including religion, belief, social class, ethnicity. And what that looks like for most of our clients is that an individual, say, is at a rally speaking out against a government. They're rounded up by soldiers, they're brought to a prison, they're held there often in very filthy conditions. They're brought out and tortured, interrogated, and then put back. We have clients who have been in mock executions where they're blindfolded and lined up with other people, and people next to them have been killed, and then they're returned to their cell. We have clients who've been put in these Sophia's Choice type situations. I had one client who they handed her a telephone, and on the line was her husband and her brother, and they said, "Who do you want? Who should we torture first?" So this kind of trauma, in some ways, is similar to other forms of trauma where there's a human involved. They're very, very personal. They're very destabilizing. I don't know if that answers your question.
Thank you, Madam Chair.
Thank you. Representative Pearson.
Thank you, Madam Chair. And I guess I also wanted to point out, as it pertains to Representative Fisher's question earlier, I believe when we've amended this, we were adding $500,000 under appropriations into the B section there. And as we read that, it looks like we're providing, trying to provide a determination of whether or not the tools that you're describing in the statistics that you are referencing, that we're actually trying to figure out if that's something that we could develop a little bit more extensively for other aspects. And I don't know if you could just share a little bit of that, because I think that's a big deal within this appropriation, and I'm really supportive of that. And I think it's getting lost in the details of all of the other great work that this bill is going to do. But if you could just speak to that briefly.
Ms. Beckman.
To the measure.
Yeah. Madam Chair, Representative Pearson, thank you. Yep, so this measure, I have it in front of me, is a 37-item measure that really looks at social functioning. And the idea that largely came from DHS, who were really excited when they saw this measure, was to say, this is wonderful that you're looking at this with your clientele, but can we adapt this to work to test how other populations across the state of Minnesota are functioning? So torture survivors are certainly a very, very vulnerable population, and there's also lots of other vulnerable populations in the state. And so that's the concept behind it. We have some ideas in mind in how this would work, including developing, adapting the measure, then testing it at 5 or 6 different test sites that serve different populations, taking it back. It would be a very close partnership between our research team and the research team at DHS.
Representative Pearson.
Again, there's a lot of great work being done here. I think that tiny little nugget in the scheme of things may be one of the strongest things that emerges out of future health and human services support for people. So appreciate that work, and I hope it all work out.
Representative Albright.
Thank you, Madam Chair. If we talk about torture or, trauma-informed, procedures and that type of thing, but we don't typically, and your testimony is very compelling, but in terms of the size of the population that suffers from this, I don't think that we've really touched on that. Mm-hmm. I'm just wondering if, and I heard estimates that it might be as large as 30,000. Mm-hmm. I don't know if that's accurate, but I'm wondering if you can speak to the size of it, and if there are demographics within that we should be informed of as we look forward to the data that comes out of this.
Mr.
Thank you, Madam Chair, Representative Albright. And just in terms of the size of the issue, our research team in 2015 conducted a meta-analysis of all the available studies of refugees arriving in the United States since 1980. And pegged the prevalence of torture among arriving refugees at about 44%. That would mean 1.3 million refugee torture survivors since 1980, 1 out of every 256 Americans. The 30,000 figure was pre that study. It could be 50,000, 60,000 in Minnesota. One of our board members is quite fond of using the analogy of enough torture survivors to fill U.S. Bank Stadium. Torture is a very shaming proposition. Survivors are not, there's no census. Mm-hmm. There's no way to count It often will take people several months to disclose the nature of those intimate violations in our counseling programs. So the numbers are large. People will, in terms of the demographics, you would look at the different refugee populations that have been arriving in Minnesota in recent years. Over the past couple of decades, of course, we've seen a lot of African refugees. In recent years, Iraqis, Bhutanese, and Karen have been resettled here in relatively large numbers. So it would be those populations. Would note also that we do see quite a number of asylum seekers in our programs, especially as refugee arrivals have been depressed in recent years. There are studies that peg the prevalence rate among the asylum-seeking population at comparable levels to the refugee population. So as we see more asylum seekers arriving in Minnesota, we see a larger number of torture survivors as well. And they come from throughout the world. They come from the Northern Triangle, for certain, as is in the news today, but a substantial number of our African clients present at the southern border as well.
Thank you, Madam.
Thank you. Yeah, we do have a large populations of refugees and immigrants, and I'm sure many of them are being impacted or has been impacted by torture. But for the reference of your bill, just for clarity for myself, I believe I heard you state that you, in your work, will be working with 52 individuals with two paraprofessionals who will have 26 clients each. Is that what I heard, Mrs. Beckman?
Madam Chair, what it would be is 3 sites, and each site would have 2 case managers and 2 therapists. So each person would have a caseload of 26 people. So what that would allow us to do is increase our ability to work with individuals. It would be about 150 new clients at any given time. I will add to that, though, like Pete said, we try to work with the most impacted folks, but when we're in primary care clinics, what we're also doing is changing how primary care clinics work with refugees. We're consulting about our clients. We're changing practice for other refugees who might be less impacted. And this last body of work we did at these clinics allowed us to create this 170-page toolkit that is for any provider working with refugees in primary care in the United States. It's free. We've just released it last week. Over 32 states have already downloaded it, so we're pretty excited. We work intensely with our clients, but then we're also impacting the greater community to better work with refugees and torture survivors.
Okay. So there being no further discussion, the chair renews a motion that House File 1875, as amended, be recommended for re-referral to the Committee on Ways and Means. All in favor say aye.
Aye.
All opposed? The motion prevails, and House File 1875, as amended, is recommended for re-referral to the Committee on Ways and Means. Thank you so much. Thank you. We're going to bring back Representative Huot. All right, so the chair moves that House File 147 be recommended for re-referral to the Committees on Ways and Means. Again, we have the bill before the committee. There is an author's amendment, and so I would like to entertain a motion for the A2 author's amendment. Representative Fisher? You did.
Madam Chair, yes, I'd like to make that motion. Have we already moved it off the table?
Yes, we're moving it off the table.
All right. I'd like to move the amendment.
Thank you so much. Yeah. So Representative Fisher moves the A2 author's amendment. All in favor, say aye. Aye. All opposed? The motion prevails and the amendment is adopted. Representative Huot, is anything else that you would like to share about the bill before we move it?
No, Madam Chair, I believe we've covered what we had to cover to make sure that this gets in the way we want it, and hopefully we can progress and get this good service on the road.
Representative Pearson, do you have a question? Okay, thank you. There being no further discussion, the chair renews a motion that House File 147, as amended, be recommended for re-referral to the Committee on Ways and Means. All in favor, say aye. Aye. All opposed? The motion prevails, and House File 147, as amended, is recommended for re-referral to the Committee on Ways and Means. Thank you so much.
Thank you, Madam Chair, and thank you, committee.
Okay, the next bill is House File 1340, Representative Lien. Okay, the chair moves House File 1340 to be recommended for re-referral to the Committee on Ways and Means. Members, we have the bill before us. Representative Lien, please present your bill.
Thank you, Madam Chair, committee members. I appreciate you hearing this bill today, House File 1340. And this bill is the mental health parity bill this year. And a little background on the bill: the Mental Health Parity and Addiction Equity Act of 2008, also known as the Federal Parity Law, requires insurers to cover illnesses of the brain such as depression, opioid addiction, no more restrictive than illnesses of the body such as cancer or diabetes. Health plan parity has consistently been a bipartisan issue, with both Congressman Ramstad and Senator Waldstone serving as key advocates. And this bill was introduced last session by a member of this committee, Representative Albright. There are three components to mental health parity. Health plans cannot charge higher out-of-pocket costs for mental health and substance use disorder treatment. Health plans cannot set arbitrary treatment limits for mental health or substance use disorder treatment. And health plans cannot use non-quantitative treatment limits, or NQTLs, more restrictively to limit access to mental health or substance use disorder treatment. NQTLs are a tool health plans use to manage their benefits set. Health plan parity stipulates that the standards that a health plan uses to determine the benefits for mental health and substance use disorder treatment cannot be any more stringent or restrictive than it is for other categories of health care. Under parity, health plans should have a process to cover new treatments, and it should be the same for mental health as it is for cancer or heart treatments. Despite federal and state law, mental health parity is still not being enforced because we rely on consumer complaints to identify parity violations. We need to strengthen the ability of the Departments of Health and Commerce to enforce current law. And to walk through the bill, Madam Chair and committee members, this bill sets up definitions for NQTLs that mirror the definition in federal law and regulations. The health plan may not impose an NQTL with respect to mental health or substance use disorder treatment if the process for determining the NQTL are more restrictive or stringent than those applied to medical or surgical benefits. It gives more accountability by giving the Departments of Commerce and Health the authority to request information from health plans to confirm that mental health parity is fully being implemented. This includes any data on the use of NQTLs like prior authorizations, network adequacy, provider credentialing, and reimbursement. Also, medical necessity, adoption of coverage for new treatments, wait times, drug formularies, out-of-pocket costs, claims denials, in-home services, rehabilitative services, and other data that may indicate a parity violation. The bill also requires therapy visits and medication maintenance to be considered as primary care for the purposes of copays and deductibles that a plan enrollee must pay. The bill also requires the Department of Commerce and the Department of Health to monitor the implementation of mental health parity and ensure that healthcare plans are following mental health parity requirements. And an annual report to the legislature by the Department of Commerce is also included in the bill as a requirement to issue to make sure that their efforts to enforce the parity law, including any enforcement actions taken, are transparent and known to the legislature. This increases transparency and creates new enforcement mechanisms that will lead to better and more equitable healthcare outcomes in Minnesota. And at this time, Madam Chair and committee members, I can stand for questions, or we can proceed with testifiers.
Why don't we move to testifiers? Welcome back, Mrs. Abderholden. Could you please introduce yourself for the record and state who you're with and proceed with your testimony?
Thank you, Madam Chair. Member Sue Abderholden, Executive Director of NAMI Minnesota. And I think we can say that we've finally begun to understand that our head is actually connected to the rest of our body and that good mental health is essential to overall health. 1 in 5 people will develop a mental illness during their lifetime, and that's a significant portion of the population. And yet a significant portion cannot obtain the treatment they need to get better. Parity really is about health plans treating mental illness as it would any other healthcare condition. And this federal law incorporated into Minnesota law provided us with hope. Hope that we or our loved ones would have coverage for the treatment needed to recover. But the promise of parity has not been realized. My own family was impacted when our health plan wouldn't pay for the emergency department visit or the ambulance because it was a suicide attempt. There was a lesser percentage paid for the hospital bill and a very limited number of therapy visits. Many families like mine go into deep debt to pay for the care our loved ones need. Let me assure you, there are no bake sales or GoFundMe pages for mental health care, where it's emptying our savings, charging treatment on credit cards, delaying retirement, and more. We have a crisis in our state with an increasing number of people dying by suicide, an increasing number of people dying by opioid overdoses, and an increase of prevalence of mental illness in children. We need private insurance to come to the table and follow the mental health parity law, or we will not stem the crises and it will continue to get worse. Enforcing parity will save lives and state funding. Right now, when parity isn't enforced, people sign up for Medicaid. It's a cost shift, and the care is more expensive because care is delayed and denied until it reaches a crisis. Around the country, states and national organizations are looking at best practices for parity enforcement. All agree that prospective compliance verifications are necessary, as is retrospective review following a consumer complaint. To ensure ahead of time that plans are following the law, they need to provide information to verify this. There have been few complaints, but when you're in the midst of a mental health crisis and the treatment your loved one needs is not covered by insurance, you don't stop and think, I'll call the Department of Commerce, said no one ever. We shouldn't have to rely on complaints for enforcement. The department should review the plans ahead of time to make sure that they're following the law. Now, the plans tell us that they are following parity. This means that they have already done their own analysis. We'd like them to show the department their analysis. The data we've placed in the bill is data that they have, and it's data that will help the departments know if, in fact, they're following parity and treating mental health and substance use disorders the same as any other healthcare condition. Please provide the tools to the department to enforce existing law. Don't place the burden on people struggling with their mental illnesses or on families stretched to the max as they try to navigate the mental health system and the complexity of health plans. We're not asking for new mandates. We're not asking for new coverage. We're just asking for fairness. Thank you.
Absolutely. Thank you for your testimony. Jeff Christensen? Welcome to the committee. Please introduce yourself for the record, who you with, and proceed with your testimony.
Thank you, Madam Chair, members of the committee. My name is Jeff Christensen. I have lived in Lakeville for 16 years. I'm here today to speak about my son, Drew. Drew was diagnosed with bipolar II in the summer of 2014 after he had completed his third year of studies in chemistry at the University of Minnesota. He understood lithium as a chemist, so he took it regularly. But over time, his swings became more pronounced, making it a struggle for him to perform in his classes. He did finally receive his diploma after completing his studies in the spring of 2016, and soon after that, he landed a job as a contractor at 3M. In 2015, my wife and I attended a NAMI family-to-family course on mental illness so that we could learn how to be more helpful for our son. It was there that we learned about Guild Incorporated, a community mental health organization in St. Paul. I wish I had known about Guild when Drew was first diagnosed, because they offered care coordination, which assesses the kind of care someone needs and how to help them. And they had a range of services, including residential treatment. Drew was taking his lithium regularly, but my wife and I longed for him to agree to therapy so that he could learn better coping skills. He resisted. And there was no way that we could force this athletic and sometimes hot-tempered young adult to go. His job at 3M lasted only a couple of months due to an outburst with his supervisor. I had hoped that this would be the natural consequence that would persuade Drew to seek therapy, but he landed an even better job right away, assisting with research at Ecolab. He was a contractor again, but this was a dream job with a path to full-time position. We suspect that Drew stopped taking his meds once he landed his position at Ecolab. He was living at home with us, and we noticed his behavior becoming more erratic. He worked long hours because he wanted to excel. He was using alcohol and marijuana to self-medicate. and this sometimes led to frightening behavior and destruction of property. Nancy and I had already been meeting with a social worker from Guild on a private pay basis because we wanted to learn how to respond when Drew became threatening. On September 11th, Drew became violent, and we asked the Lakeville Police to help us. He was taken by ambulance to HCMC, where he spent the next 10 days in their adult psych unit. Our private insurance paid the majority of his hospitalization and half of the ambulance ride to the hospital. After his discharge, he returned home and discovered that he had lost his dream job. About a week later, he was hospitalized again, and this time was prescribed an additional medication to help suppress psychotic episodes. He was discharged on September 29, 2016, and we knew he needed more services, maybe even residential, but it didn't appear that our insurance covered any of these things other than meds, hospitalization, and therapy, and he needed more. We went to the county on October 7th to see what services he could get there. It was part of our discharge plan, but in the intake meeting, it turned out to be a trigger for my son, his anger and his impatience, because our entire first meeting was about how those services would be paid and filling out numerous consent forms to share information. We didn't know it at the time, but the risk of suicide is heaviest during the first 90 days after someone is discharged from an acute mental health hospitalization. We had private insurance, but here we were at the county trying to figure out if Drew would be eligible for Medicaid because he was now unemployed. Medicaid would have covered additional services that he needed. On Monday, November 7th, I reached out to the county social worker. I hadn't heard from her for a while and wanted to know about the next steps. She got back to me the next morning to let me know they were still trying to figure out whether Drew might qualify for Social Security disability or Medicaid. That afternoon, we received a call from the Lakeville Police. They told us our son had died that morning. He had climbed the railing of a bridge. Someone stopped and asked if he was okay. He said no and stepped to his death. When our son was first diagnosed, we didn't even know what questions to ask. No one does. We desperately needed someone who could act as quarterback so that we could return to being parents. When Drew was being discharged from the hospital, I still didn't know what services to ask for, but I know with certainty that he needed more. We knew about Guild and the model they had developed over the years, and it was working for other people, but it was out of reach to us. I believe my son could be alive today if the intensity of services provided by Guild had been available to us under our private insurance. Thank you, Madam Chair, members of the committee.
Thank you, Mr. Christensen, for your testimony, for sharing your story. And just want to say, your loss of your son is
Thank you, Madam Chair.
a terrible place we have to be to hear the need for some parity. But thank you so much for coming before us. Is there anyone else in the audience who would like to testify on House File 1340? Members, any questions? Representative Albright.
Thank you, Madam Chair. First, I want to thank the author of the bill, Representative Lien, for being a champion on this cause. You and I share a similar desire to help those that are most vulnerable amongst us. So thank you for being their hero this year. And to Ms. Aberholden, thank you for being the constant champion for these people. It is without too much thanks, but your work is hopefully going to be rewarded.
Hope so.
And to Mr. Christensen, I share your long-term desire to help those that are in need of much needed help. So, members, I urge wholehearted support of this bill.
Representative Edison.
It's like ping pong back and forth. So Heather, thank you, Madam Chair. Thank you for bringing this bill. I think it's so important. Oftentimes people are going to, say, an internist or a physician when really they should be going to a therapist. And I think it's so incredibly important that we value the importance of mental health in our community. So I want to thank you for bringing the bill. Mr. Christensen, I am so sorry about your son's loss. That was a failure of our system, and I apologize for that. I just want to know if there's, in terms of working with the plans, in providing, have they provided documentation at all in terms of how they're following the parity right now? Ms. Abderholden, do you know if they've provided anything to you on this yet?
Ms. Abderholden.
Madam Chair, Representative, you would really need to ask the Department of Commerce or Health. We know that they asked some additional questions this year, particularly related to residential treatment, but I wasn't in the room, and they meet with the plans individually, so I really can't answer that question.
Madam Chair,
Anyone here from the Department of Health or Commerce who can speak to the question?
Madam Chair, for the record, Peter Brickwitty, Assistant Commissioner at the Commerce Department. I wouldn't want to speak for my colleagues at the Health Department, but representative to your question, yes, we have conversations and are having ongoing conversations with the health plans on an individual basis about how they are viewing parity compliance. However, I think, and we talked about this in the Commerce Committee as well when this bill was up earlier this week, that having additional reporting in the law helps clarify to everyone what needs to be accounted for and then also reported. And the transparency that comes with the legislative reporting as well from the departments, I think will help make that information public and publicly available so that it can be used for future purposes.
Representative Edison.
Thank you, Madam Chair. I just want to make sure that that's great that we'll be doing this because we need to be holding people accountable, and that means from industry to the people that are delivering services. Thank you.
Okay, Representative Pearson.
Thank you, Madam Chair. And, I actually had some psychiatrists in my office earlier this week, and just to this specific issue, and so maybe someone from the department can kind of guide me through how I should be asking this question even. It's even within facilities where they're doing prior authorization for mental health and doing prior authorization for, just traditional medical care, they've been tracking how much time they're even placed on hold. And the measurement demonstrates it's about 5 times longer. And I've never heard that prior authorizations are done quickly anyway. But in this area, and we talk about parity, when they're able to track that just on how long they're placed on hold, being 5 times longer, I can only anticipate that just gets amplified through the rest of the system. And I guess that's something, are we quantifying this in any way? How do we demonstrate the lack of parity at this point, and how do we move forward to do measured accountability in this area?
Do we have anyone here from the Department of Health who can also speak to this question? Please introduce yourself for the records.
Thank you, Madam Chair and members. My name is Diane Rydrick, and I'm the Director of the Health Policy Division at the Minnesota Department of Health.
I'm sorry. Please
Continue. Yes, so Madam Chair and Representative Pearson, I think I would largely echo what Mr. Brickwitty said. We've been starting to have conversations with many of the carriers to understand what the metrics are that they track to help inform what we might request of them if this bill or something similar were to pass going forward. And we have heard of a number of indicators that the plans do track internally. I don't know that that specific one has come up in our conversations yet related to hold times, but we have asked about prior authorization and out-of-network usage and copays and other things that we think would be important for us to track, and we want to understand what they're looking at internally to kind of help inform those efforts. I would agree with Mr. Brickwitty that having that sort of ability to collect information in a more consistent way across all of the carriers across the market and to be able to make that information more publicly accessible would be helpful for us and would be a step forward in increasing transparency around compliance with parity requirements.
Representative Pearson.
So the Department of Commerce is also asked to submit an annual report about mental health parity. That's what we're using to analyze this, or how would you demonstrate? Again, this is a great bill. I really appreciate it, but much of this is already required, and we're not getting the job done. And so, we can do a lot in this committee to pass more laws, but if the laws aren't being followed currently, I guess I'm trying to get some assurance that what we're doing here today is going to get to the root of the problem, and why aren't the current laws already addressing this?
Representative Lien.
Thank you, Madam Chair. To your question, Representative Pearson, I certainly understand that, and we talked about that in the Commerce Committee a little bit. Just we have these laws in place, federal laws. Why aren't they currently being enforced? And I think the purpose of this bill is to help the Department of Commerce better understand what information is needed so that they can better enforce these laws. Currently, right now, it's really just based on consumers or patients and their families reaching out to the Department of Commerce and saying, hey, we need a little help here. We need some better coverage from the insurance plans. And so I think this would better help Commerce understand how to enforce parity, what the issues are, what the challenges are families face, ultimately to get better care out of these health plans that they're already paying the premiums on. And so really to help Commerce better get the services out to people that they are frankly already paying for.
Representative Pearson.
Yeah, Madam Chair, I do think we use the term consumer, and that's important. I definitely the person that's cared for or inappropriately cared for, as has been testified this morning, and I also I'm sorry for your loss, and I can't imagine going through that experience, and I appreciate you sharing that testimony today. And not to lighten that burden or who that consumer is, but the providers themselves are an internal consumer as well. And if they can't access, or like I say, they're put on hold for 5 times longer, it's one of the biggest complaints that I hear from providers in almost any area of healthcare right now, is how long it takes to get prior authorization, and how they could be seeing more patients if they weren't sitting on hold, or if they didn't have to make 5 or 6 phone calls to get the prior authorization that they need. And so I get that currently the only thing that triggers this is a consumer's complaint, but we've got practitioners who are familiar with how these interactions between the insurance company and the provider should be taking place. Is their voice being heard? Are those complaints being addressed? And again, we're in the policy committee right here, so that's why I really want to make sure that this is going far enough and that we're getting what we need here, because we've got a long way to go.
Mr. Brickwady, you look like you.
Madam Chair, Representative Pearson, I think actually to both of your questions, I think to your first question, I think that's actually a great question to ask the plans, because the plans could be able to tell you what they're tracking internally to make sure that their plans, or products, that they're bringing to market are at parity. So I'd encourage you to ask them that question as well. To your second point about providers, yes, we have worked very diligently to improve our communications channels with providers who the Commerce Department does not regulate. Since 2015 in particular, we have deepened our connections with both the trade associations and with individual providers, and I know that work has occurred over at the Health Department as well too, and that was very important for Minnesotans who have concerns about parity issues, because I think, as Ms. Abderholden has said, There's very little about the name of the Department of Commerce that tells you that we're an agency that can assist with parity-related complaints or concerns. And typically, an individual who is in the midst of a mental health crisis is not necessarily going to be in a position to come to their insurance regulator and ask for assistance. It's going to be a family member, a caregiver, or in many cases a provider. Because we don't regulate providers, we don't license providers to do their work here in Minnesota, we had not traditionally had deep connections to the provider community. Because we didn't have other business with them. And so we have built those connections. We do receive complaints directly from providers, as does the health department. So I agree with you wholeheartedly that we need to, in state government, be open to have as many accessible channels available to individuals and their families and their caregivers who have concerns about a patient's ability to access mental health services when they need them.
Representative Pearson.
Thank you, Madam Chair. And I guess I have to look. I look to the way that it's being done, and it's not working. We're getting failing scores from independent entities that track this stuff, and other states around us are doing very well or just fine. Do they follow the same structure where commerce is involved? Are we trying to reinvent a wheel by making it square? Are we doing something really wrong here? And I know the intentions are all very good, and yet all the best intentions, if they're failing the people in the state of Minnesota, are not well placed. And so I just have to ask a couple of those questions just to see if there's something else we should be looking at. And again, just honing it out here, obviously we've got probably a couple more stops as it goes to make changes if we need, but just looking for additional understanding of how it's going so wrong.
Madam Chair, Representative Pearson, I'd be happy to connect with you about what some other states have been doing. For our part at the Commerce Department, we have been engaged with our counterparts through the National Association of Insurance Commissioners, helping to lead a group of states that are working both together to improve and coordinate their efforts from enforcement, statutory requirements, and coordination with our counterparts at the federal level, both at the Department of Health and Human Services and at the Department of Labor. And Representative, I agree, and I think the department shares your desire to resolve this so that we are in compliance with state and federal requirements, because at the end of the day, it is the patients, the people who need healthcare services, who need to be able to access them when they need the services. I think that, Representative, if we had found the silver bullet to solving this problem, we would have shot it quite some time ago. I think this bill moves us in the right direction. One of the things that we have found in discussions with all of the groups that we've been discussing about here today is that there is some opaqueness to the issue of the use of non-quantitative treatment limits, and so I think this bill is going to help both the insurance regulators and the plans identify in a better way what is actually happening through the use of NQTLs, and the reporting to the public through the annual report from the departments to the legislature, I think will also help that information be available more broadly than it would if it was just contained in the regulatory process only.
Thank you, Mr. Brickwady. Further discussion? Representative Pearson.
Well, and again, this isn't my area, and we can certainly talk about it offline. Specifically, the state of Illinois gets an A grade in this. Are they using kind of the same basic framework, though? I mean, that's what the gist of my last question was. Is there a structural failure in what we're doing?
Mr. Brickwady.
Madam Chair, Representative Pearson, the state of Illinois did pass a very comprehensive wholesale revision to its state parity laws that has been very well received by national parity focused organizations. That bill is more expansive in scope than the one before you here today. There are parts of that bill that sort of brought Illinois to where Minnesota has been for quite some time in terms of what the state standards are in place. There are some things that Illinois did that probably go beyond what we have in state law here as well. I know that the Kennedy Forum gave Illinois a very high grade in that same report that they gave Minnesota a less than good grade, and it was in large part because of some of the changes that they enacted. So I think there are other states that have been real leaders in this space as well, Rhode Island, Pennsylvania, and so we are working with all of those states through the NAIC and our counterparts at the insurance departments in all of those states, and would be happy to work with you, Representative, on any ideas that you'd like to bring forward.
And Ms.
Representative Pearson.
Abderholden is coming down too to answer that. I wonder if you're running for office, because that was the most diplomatic way to say we're getting a failing grade, as you could, is to say it's less than an A is certainly one way to word it. But Ms. Abderholden, if you can enlighten us further, I'd appreciate it.
Ms. Abderholden.
Thank you, Madam Chair. Representative Pearson. Yes, Minnesota got an F. We had a stronger version of the bill that we honestly knew that we couldn't get passed. And so the language in here is a compromise between having a task force and putting it off for another year, or doing the full-blown mental health parity analysis that has been passed in other states. We still think this will get us somewhere, which I'm going to be honest, I don't want to wait. I don't want to have another task force. This is basic data that will help us figure out how we're doing, and perhaps in future years we'll learn from this and can come back with something stronger. But our original bill was based on the National Parity Coalition's kind of model bill that has been adopted in Illinois and some other states. But this is an important step forward, and so we fully support this so we can move forward on this.
Representative Pearson.
Well, I appreciate that answer, because my notes then also talk about the work group's language, and is that what you're referring to as the stronger bill that was out there then, is the language that came from the work group, or is this language representative of that?
Ms. Abderholden.
Madam Chair, Representative Pearson. No, the work group was from last year as a compromise from the full-blown bill. And so we had introduced the full-blown bill, not the task force bill this year, and then went to this amendment so that we could at least get some basic data, but not have to wait for a work group for a whole nother year.
Thank you, Madam Chair, and I guess
Pearson.
I think the will of this committee, at least, and I can't speak for the whole legislature, but I mean, I guess I would want to put the insurance providers on notice that I feel we aren't going far enough. And again, Representative Lien, I appreciate you carrying the bill. It's certainly important work, and if this is truly the best we think we can do right now, I respect that, but I sure hope the insurance companies out there will take heed to the fact that we need solutions and we need to make progress. And I don't think it requires tougher language. I just think it requires the will, and we should be able to make that happen. So I appreciate all the work everyone's doing on this bill.
Thank you.
Further discussion? There being no further discussion, the chair renews her motion that House File 1340 be recommended for re-referral to the Committee on Ways and Means. All in favor, say aye. Aye. All opposed? The motion prevails. House File 1340 is recommended for re-referral to the Committee on Ways and Means.
Thank you, Madam Chair, committee members.
Thank you. Okay, Representative Baker, House File 1718. The chair moves that House File 1718 be recommended for re-referral to the Committee on Ways and Means. We have the bill before the committee. Representative Baker, can you have an author's amendment?
I do, Madam Chair.
The chair will entertain a motion for the DE1 author's amendment.
I'd move the DE1 amendment, Madam Chair.
Representative Albright moves the DE1 author's amendment. All in favor, say aye. Aye. Opposed? The motion prevails and the amendment is adopted. Representative Baker, please present your bill.
Madam Chair, thank you so much for helping me out with the schedule today and moving this up. I bring to you the agency bill for the Board of Pharmacy. I just want to take a moment to say thank you to Dr. Weiberg, who has been a a champion for me the last couple of years, working on a lot of new directions and new innovative stuff with opioids and how we want to address things. So with that, I'm very proud to carry his bill this year, Madam Chair. With that, I'm going to let him kind of explain it. The DE really takes out a lot of the anything that's controversial. We don't have to make a commerce stop with this, and I think Dr. Weiberg will explain that, and he'll be as brief as possible. So thank you, Madam Chair.
Thank you. Dr. Weiberg, please proceed.
Madam Chair, members of the committee, I'm Dr. Cody Weiberg. I'm the Executive Director of the Minnesota Board of Pharmacy. And the DE amendment does remove quite a bit of the language in the bill. When I realized we were getting close to deadlines, I wanted to take anything out that might even possibly be controversial and require any other committee stops. What remains, first of all, looks like a rather large bill, but 50% of the language is actually a big technical fix. So about not quite a half a dozen years ago, Congress passed a bill called the Drug Quality and Security Act, and half of that bill dealt with compounding. The legislature has already helped us out with language we needed to address the compounding issues. The other half of that bill dealt with drug wholesaling. And our drug wholesaling system in this country does have quite a few problems. So in a nutshell, what Congress did is it passed new national standards for licensing drug wholesalers, and it put in a state preemption clause. It preempted all existing state language in that area. And so all of our drug wholesaling language is obsolete. And so what I did is I took the federal language for drug wholesaling, put it into state format, and that is 50% of the bill. I've talked with the Trade Association for the Wholesalers, the National Trade Association, and they are fine with this because it does what we have to do, which is conform state law to the federal law. Several of the sections, I've been working with the Minnesota Department of Health on syringe provider services. So people who do use drugs intravenously on the street, if they are sharing needles, they are much more likely to be also sharing diseases such as HIV, hepatitis B, hepatitis C. So this state, like all states, have had syringe exchange programs for many, many years. This is language that finally adds a formal definition of what syringe service providers are, and recognizes in the statute that those providers and the people that use the services can actually have the syringes as well. And both the board and the Department of Health think that that is a very important public health policy initiative to prevent the spread of those diseases. And there are a couple of sections, 11, 12, and 13, that give the board a little bit more flexibility in determining what sort of documents that out-of-state facilities that ship into the state have to send us. After that compounding disaster that prompted the federal legislation, we came back to the state, and I have to say that we wrote our requirements for out-of-state facilities a little bit too strict, and it's been difficult for some out-of-state facilities to meet these standards. So what this would do would be allow the board, instead of requiring every manufacturer, wholesaler, medical gas distributor out of the state to submit a full inspection report, this would allow us to focus on the types of facilities that we think are dangerous and causing problems. A couple sections clarify that outsourcing facilities, which is kind of a hybrid between a pharmacy and a manufacturer, they have to follow manufacturing standards, and therefore they have to have manufacturing inspections. There is one piece, two pieces actually, I've worked with the Minnesota Veterinary Medical Association that they are interested in. The language that we passed about compounding that the legislature passed forbids any sort of compounding of any products that would be, instead of given to the patient, would be sent to a practitioner's office for use in the office. And in talking with the veterinarians, they explained to me that because they have to treat anywhere from a 2-pound teacup Chihuahua to a 120-pound Great Dane, there aren't enough commercially available products for certain emergency situations, and they really need compounded products in some circumstances. So this would allow pharmacies to compound products for veterinary office use if it were to meet certain emergency conditions. And then there's some technical changes in the repealer, repealing the cancer drug repository program. I think is the biggest thing there. Most of the repealer is repealing the old sections of drug wholesaling law because we're putting new sections in. We're proposing to repeal the cancer drug repository program for two reasons. One, it's never been effective. We've never had anyone that's ever wanted to do it. And two, there's a bill moving through the legislature, almost got enacted last year, that would create a much broader repository program. So this wouldn't be in effect at any rate if that bill does get signed into law. And with that, I will take any questions members might have.
Thank you, Dr. Weiberg. Is there anyone else in the audience who would like to testify on House File 1718? Okay, Representative Albright.
Thank you, Madam Chair. Dr. Weiberg, and this may be a question either for you or for someone from the Department of Health, but I just wanted to get some clarity on sections 3, 18, and 19.
I'm sorry, what was that?
Sections 3, 18, and 19, but maybe we'll just dwell on subdivision 42, which was on page 2 of the DE.
Mm-hmm. Okay.
Dr. Weiberg.
There's a lot of language there, Dr. Weiberg, and I'm just wondering if you could elaborate on what that really means.
Dr. Weiberg.
Madam Chair, Representative Albright, I'll take a stab at this. This is the language part that the Department of Health put together, but they register entities currently to be syringe services providers, and I think what they are trying to do here is to make sure that there's a good definition of who can actually participate in this sort of a program. And so these services that are listed here, these are the services already being performed by these syringe service providers. They're also sometimes called needle exchange programs. And so they do these things. One of the primary things they do, of course, is to allow people to come in and get clean, sterile needles and syringes to use. But, that's not enough. This helps prevent these individuals from contracting and spreading diseases, but they need treatment. And so the service providers also will do referrals to chemical dependency treatment. They will educate individuals about if they're using intravenous opioids, how to try to prevent and treat overdoses. They will emphasize how important it is to properly dispose of the needles and syringes. They'll even hand out like free sharps containers that people can store these in. So they do a variety of different things. So this is really creating a definition in statute that's somewhat been missing over the last at least couple decades that these programs have been operating.
Representative Albright.
Madam Chair, I wonder if someone from the Department of Health could come down for a question.
Please state your name for the record and proceed.
Thank you, Madam Chair. For the record, my name is Melissa Finnegan. I'm the Legislative Director at the Department of Health. Representative Albright, for my benefit, could you please repeat your question?
Representative Albright.
Thank you, Madam Chair. Ms. Finnegan, it's a fairly substantial piece of language that we're inserting into this. And a couple things, I'm just wondering what the genesis for the language itself is. Are we looking to fix a problem, or are we looking to put something into definition that finds safe harbor for those that are offering the service? I'm just wondering the why and the wherefore for the need for subdivision 42.
Ms. Finnegan.
Thank you, Madam Chair. Representative Albright. Subdivision 42 is actually just codifying existing practice. As Mr. Weiberg said, the Department of Health over the years has funded the syringe services programs across the state. We currently fund 6 in the state of Minnesota. So what Subdivision 42 provides is a definition of what these services are and what they're providing to Minnesotans to codify existing practice.
Madam Chair.
Representative Albright.
Thank you, Madam Chair. Ms. Finnegan, So it's cost neutral to the providers, and I'm just wondering if that would be also the nature, if it's a pharmacy itself, would they be reimbursed for the cost of providing that service as well?
I look to Mr. Weiberg for that one.
Dr. Weiberg.
Yeah, Madam Chair, Representative Albright, actually, pharmacies are allowed under the law to provide up to 10 new sterile needles and syringes. There are many pharmacies doing that now. They are not required to provide all of these other services. They are required to certify to the Commissioner of Health that they have done something to encourage the proper disposal of the needles and syringes. And that doesn't have to be giving away Sharps containers, for example. It can be, they can sell the Sharps containers, of course, but it can also be referring them to places that do accept the Sharps free of charge, or to provide printed materials about how to dispose of them. But they don't have to provide all of these other services. And when they do provide the needles and syringes, they're allowed to charge them. This really doesn't change what pharmacies can do so much as it codifies these other 6 providers that are out there.
Representative Albright.
Thank you, Madam Chair. Ms. Finnegan, in the language itself, you talk about education about overdose prevention, and Dr. Weiberg talked about, and he mentioned opioids. And I know that we're in the throes of wrestling with that very subject, and so I'm wondering, is this a function of where these providers are going out into the community to provide these services, or is this where they're waiting for the community to come to them? I know it's distinctive in the practice of, where does the liability fall? From my background, I'm just wondering, is it a push or is it a pull?
Ms. Finnegan.
For the service.
Madam Chair, Representative Albright, that is an excellent question. I am not the content expert in this area. We had anticipated this bill to be up much later in the agenda. Our content expert is not here, but I can take that question back to them and get you a response probably before this meeting is adjourned.
I think I recognize that the gentleman to your right is going to phone a friend here for you.
Oh, great.
Dr. Weiberg.
Madam Chair, Representative Albright, I'm not the MDH content expert, but I've worked with them for months on this bill. And I think what they've told me about these programs is they do both. They allow people to come to the facility, but they do outreach, and I believe that they do actually send people out into the community, from what they've told me.
We can confirm that, Madam Chair.
Thank you. Further discussion? All right. There being no further discussion, the chair renews her motion that House File 1718 as amended be recommended for re-referral to the Committee on Ways and Means. All in favor, say aye. Aye. Opposed? The motion prevails. House File 1718 as amended is recommended for re-referral to the Committee on Ways and Means.
Thank you, Madam Chair.
Congratulations. Thank you, Representative
Thank
Baker. Representative Brand, House File 2379. Yeah, no kidding.
Morning.
Good morning. The chair moves that House File 2379 be recommended for placement on the general register. We have the bill before the committee. Representative Brand, please present your bill.
Good morning, Madam Chair, members of the committee. This bill does 4 things. House File 2379. The first provision is the bill allows for improved data sharing between the Department of Human Services and the Department of Public Safety. That will ensure the medical assistance serves as the payer of last resort. The second is the bill will create a 60-day voluntary return to a secure treatment setting for a non-secure setting from patients in direct care and treatment forensic services, as well as clear authority for the medical director to return to a secure setting. The bill also changes the length of time following a court-ordered provisional discharge or discharge from the order that can be implemented for a client from MSOP from 15 to 30 days. This change ensures that MSOP's clients' safe and successful re-entry into the larger community after a court decision. Specifically, it will allow more time to make sure things such as community notification by law enforcement and safe, stable, appropriate housing are in place prior to discharge. Finally, the bill amends the statute to cover the transfer of all forms of bodily fluids as a means of fourth-degree assault against forensic staff. This amendment also demonstrates the commitment to staff safety, which I support, and personal accountability for patients being treated at all direct care and transfer facilities. And with that, I've got Robin Benson, Deputy General Counsel for the Department of Human Services, and he'll walk you through the rest of the bill.
Thank you. Please state your name for the record and proceed with your testimony.
Thank you, Madam Chair. Thank you, Representative Brand. My name is Robin Benson. I'm Deputy General Counsel at the Department of Human Services, covering the direct care and treatment part of our agency. So I'll walk through the provisions of the bill. The Section 1 is a section that was amended at the last stop at Judiciary. It relates to a different part of the agency than direct care and treatment. It provides, as Representative Brand explained, a additional data sharing between the Department of Public Safety and the Department of Human Services for the purposes of third-party liability in the medical assistance context, so that Medicaid truly is the payer of last resort. It allows Department of Public Safety, or requires Department of Public Safety to provide some additional information in addition to what they already provide, so that the department staff can more quickly identify cases where someone else would be the responsible payer. Turning to the other sections, sections 2, 3, and 4 of the bill are changes to the civil commitment statute regarding mentally ill and dangerous individuals. They clarify the procedures involving the transfer of patients committed as mentally ill and dangerous between the security hospital and its transition services unit, both of which are on the campus outside of St. Peter. These provisions are modeled on similar procedures that already exist involving the provisional discharge of these patients. So these are not new concepts or procedures, they're just applying to a different stage in the reduction in custody process. Specifically, Section 2 establishes a voluntary return readmission option for individuals who have been transferred to a less restrictive setting. Under this provision, a patient can temporarily return to a higher level of structure and familiarity within the secure facility to work on issues that may have arisen that have caused them to need to restabilize before returning to that setting, and to do so without losing their place in that setting and not having to go through the semi-lengthy process that it takes to get back out. Under this provision, the medical director decides whether to allow the patient to return to the secure facility, and also determines whether the individual can return back to the less restrictive setting. If the individual is not returned after 60 days, then it acts as a rescission revocation is the word, and they have appeal rights that are provided for in this section. Section 3 makes clear the medical director's authority to revoke a patient's transfer and return them to a secure unit. It's different than the voluntary return. It is a proactive measure that the medical director has based on clinical determinations about the patient's needs as well as safety to others. It provides that process, also provides appeal rights to the patients. Section 4 makes minor conforming edits to the existing provisional discharge revocation appeal subdivision, just specifies with those changes that it covers provisional discharge, because the other sections are covering appeal rights around transfer revocations. Section 5 is a different commitment population. It relates to Chapter 253D, the civil commitment of sexual offenders. It changes the number of days before a court order granting provisional or full discharge can be implemented from the current 15 to 30. Gives more time for the individual to prepare for return to the community, as well as for our services to ensure that that's a safe transition. Section 6 is a small modification to what behavior falls within fourth-degree assault when the victim is a security hospital employee. The change is editing out the terms urine, blood, or semen and replacing that with bodily fluids in terms of what is thrown or transferred as what constitutes the assault. So after that modification, that provision will be identical to line 5.8, which relates to MSOP employees. And so that protects all DCT secure facility employees from the same type of behavior. And I'm ready for any questions.
Is there anyone else in the audience who would like to testify on House File 2379? Discussion among the committee. Representative Albright.
Thank you, Madam Chair, and to the testifier, can you just, for my understanding, on page 2, lines 2.23 through 2.26, could you just give me a real-world example of how that works? Because the language, as I've read it 17 times now, I know it's early and I'm only on my third quart of coffee, but I don't follow it.
Okay. So in plain English, that paragraph provides that, so the first paragraph allows the patient to request a voluntary return to the secure setting. Paragraph B, and so we're at the point where the medical director has already granted that permission and says, yes, you can come back within the secure setting. At the point of the 60th day, if the medical director has determined that, no, you're not in a condition where you're going to be able to safely return to the more open setting, you have to stay, that says that the individual's prior transfer, the authority for them to be in the less restrictive setting, is revoked.
Representative Albright.
Thank you. Okay, so then I'm going to go back to the first paragraph and kind of confirm what I just thought I heard. So this is a transfer within not the facility, but the treatment program, where you're going from a more restrictive setting to a less restrictive setting, not as they would be released to the general public. It is so that they have an opportunity to experience a less restrictive setting, and if that is not conducive to their situation, mentally or otherwise, they can ask to be returned to the more restrictive setting for a continuation of the treatment plan there. And then they, at that point, would absolve themselves of the voluntary right to exit if the medical doctor decides that you are correct, you need to stay here for a while longer.
Mr. Benson.
Madam Chair, Representative, that is correct. An example might illustrate it where there are two separate facilities, but one forensic mental health program. So the Minnesota Security Hospital is defined as the secure treatment setting. A difference there is everything's locked. There's lots of a higher ratio of staff, a lot more eyes on the individual. Forensic Transition Services is the program that they would be capital T transferring to through this through a process that requires a review board and a lot of process. And that is the on-campus step where they're beginning to experience more freedom. They have the opportunity to have short outings into the community, and they're getting ready for a return to the larger community. So when they're in that more open setting, individuals who are committed as mentally ill and dangerous, oftentimes an important part of their treatment is the type of psychotropic or medication that they're on. And if they experience a change in medication, it may be more advisable for them to return to that closer setting to get them to the right point on that before returning back out. And so it's that return in where, yes, they're voluntarily saying, I want to go back, and then the medical director says, yes, you can come back, but once you come back, medical director gets to decide if you go back out.
Representative Albright.
So just as a follow-up, and I know we oftentimes talk about the level 1, level 2, what effect does your explanation infer to or connect with that type of classification?
Mr. Benson.
Thank you, Madam Chair. Representative, to clarify, level 1, level 2 in terms of risk level and community notification. So there is no effect on community notification with this type of transfer for individuals that do have a risk level, there are some members of the mentally ill and dangerous patient population that do carry a notification requirement. All of the civilly committed sex offenders do, but this is addressing just the mentally ill and dangerous part of the population. If an MIND patient has a risk level, there's no notification required because they're still on the campus. They're still in that supervised type of setting.
Further discussion? There being, Representative Bonner.
Thank you, Madam Chair. Representative Brandt. So just a curiosity, so when they go to step down to that lower classification, I know that they are allowed to take outings within the community. And I'm curious what the process is for notifying the community of that. I'm just curious because I know there have been some incidents. And so I'm just curious what that process looks like or how that plays out.
Mr. Benson.
Thank you, Madam Chair, Representative. The forensic staff work closely with the, most of the outings are in the immediate area, St. Peter, Mankato. The forensic staff work closely with the local authorities in those areas, the police department, the sheriff, and so they will alert them when there is someone who has past eligibility. So just to step back, when patients first experience community outings, they're always with staff. They're always supervised, and they've been prepared for it so that everyone knows the rules and they know what to expect. And it's a very gradual process where it's not going to go to a large crowded area. It's going to be something where first we'll take a small step to the point where they're going to be on an unsupervised outing. That's called a pass. That's also handled in a very progressive, gradual way, where the first pass, maybe you're going to be unattended for a half hour, and we may check up on you all the way to eventually having overnight passes. And each step along the way, there is communication with local law enforcement about we're going to be present, about the individual, and there's quite a bit of communication. The community of St. Peter has been, for decades, very welcoming to our forensics program, and we don't want to have anything happen so that that's not going to be the relationship.
Representative Bonner.
Thank you, Madam Chair. Thank you for that. I appreciate that additional explanation, and I do want to thank you for the additional protections for the staff in that facility. I will tell you in full disclosure that a close friend of mine happens to be one of the folks who helps run that facility. And so I know that this is a big concern for her and her staff. So I want to thank you for bringing that forward. Thank you, Representative Brandt.
Further discussion? There being no further discussion, the chair renews her motion that House File 2379 be recommended for placement on the general register. All in favor say aye. Aye. Opposed? The motion prevails. House File 2379 is recommended for placement on the general register. Congratulations, Representative Brown. Representative Masin, House File 2305. The chair moves that House File 2305 be recommended for placement on the general register. We have the bill before the committee. Representative Masin, I understand you have an author's amendment. The chair will entertain a motion for the DE11 author's amendment. Thank you, Representative Pinto. Representative Pinto moves the DE11 author's amendment. All in favor say aye. Aye. Opposed? The motion prevails and the amendment is adopted. Representative Masin, please present your bill.
Thank you. Madam Chair, members of the committee, I am Sandra Masin, and House File 2305 is the Continuing Care for Older Adults Administration's 2019 policy language. The Continuing Care Administration at the Department of Human Services oversees the elderly waiver, the Adult Protective System, the Minnesota Adult Abuse Reporting Center, the Nursing Facility Rate and Policy Division, among other duties. This bill provides necessary updates to language pertaining to the administration's business areas, including changes to the Vulnerable Adults Act, nursing facility rates, the Minnesota Adult Abuse Reporting Center, to reflect current and changing practices and guidelines in order to best serve older Minnesotans throughout the state. The policy bill is a reflection of the ever-changing needs and desires of a growing population of older adults who all desire to live safely, both in the community and in their residences. Providing a safe and quality environment for our adults, for our elders, is an extremely important topic for so many. And so I am excited about some of the changes we will discuss today, and I hope you will be as well. Here to present on the administration is Department of Human Services Assistant Commissioner Dan Pollack, and to present on the bill itself is Heidi Hamilton, the Legislative Director for Continuing Care Administration, as well as Disability Services and Deaf and Hard of Hearing Services at the department.
Thank you, Representative Masin. Please state your name and proceed with your testimony.
Hi, my name is Heidi Hamilton. As Representative Masin said, I'm the Legislative Director for Continuing Care for Older Adults, Disability Services, and Deaf and Hard of Hearing Services. In the interest of time, Assistant Commissioner Dan Pollack will be available for questions, but I'll walk through the bill with you. So I'll start with a high-level overview of what's included in the bill, and then I'll do a brief section-by-section walkthrough. So the bill includes changes necessary to modernize the Vulnerable Adults Act. The Vulnerable Adults Act was originally written in the 1980s and was based on alleged maltreatment for people in nursing facilities. With changes in where people are living and receiving services, it's necessary to update the statute to be consistent with person-centered practices and a service system that is community-based and includes informal supports. Secondly, we have technical updates to the nursing facility rate statute. In 2016, nursing facility rates were recodified, and during that process, not all of the necessary corrections were made to duplicative or contradictory language, and there are still some cross-references to deleted rule language that need to be updated. So this proposal makes corrections to address these oversights and will provide clarity of regulatory intent and transparency for nursing facility providers. And then finally, we are looking at provider standards for in-home services and how we can be more flexible in what those provider standards are for some of the more informal services that older adults need in order to remain in their homes as long as possible. So I'm going to walk through the DE1-1 amendment sections. So sections 1 and 2 update cross-references. Section 3 increases the amount of time used by the Vulnerable Adult Maltreatment Review Panel to schedule a reconsideration request. Sections 4 through 16 add clarifying language or make technical amendments to assure consistency in documentation for nursing facility rates. Sections 17 and 18 update cross-references. Section 19 updates language by allowing mandated reporters of maltreatment to submit an electronic report and clarifying that an alleged perpetrator may be someone other than a caregiver. Section 20 clarifies the content of the standard intake form used by the Minnesota Adult Abuse Reporting Center, or MARC. Section 21 makes several updates, including authorizing the lead investigative agencies to consider previous reports of suspected maltreatment, requiring lead investigative agencies to share information with the vulnerable adult about the report and the investigation process unless it would endanger them by notifying them, and requiring lead investigative agencies to complete their final disposition for a maltreatment investigation within 60 days from the date of their initial disposition. Then moving on to Section 22. This eliminates the ability of an alleged perpetrator who has a dual role as an interested person from having the right to request a reconsideration of a determination on behalf of a vulnerable adult that they have been alleged to have mistreated. Section 23 updates the requirements for the lead investigative agencies during their investigations. Section 24 clarifies that lead investigative agencies can exchange data for the protection of the vulnerable adult when it is necessary to prevent further maltreatment, safeguard the affected vulnerable adult, or to initiate or complete an investigation. Section 25 updates the definition of abuse and updates language regarding the use of aversion and or deprivation procedures to align with our state of Minnesota policy, as well as federal patient rights. Section 26 updates the definition of caregiver to be consistent with state policy to support and encourage family members to identify as caregivers. Section 27 updates the definition of financial exploitation. Section 28 updates the definition of neglect to distinguish between self-neglect and caregiver neglect. Section 29 adds a new subdivision to define a primary support person for the purposes of protecting a vulnerable adult from further maltreatment or abuse. And Section 30 directs DHS to make recommendations to the legislature on adjusting provider standards for companion, homemaker, and respite services. So I realize that that was a very quick run through and a high level, but I'm happy to answer any questions that you might have.
Thank you. Is there anyone else who wants to testify on behalf of this bill in the audience? Representative Edelson.
Thank you, Madam Chair. So for Section 22, starting on line 15.27, I guess I want to just go over why some of the language changes, like the relationship on line 16.24, you strike the relationship of the alleged perpetrator to the alleged victim. I mean, it looks like you're moving that up. I'm just curious why the restructuring and what was the aim of this here.
Ms. Hamilton?
Madam Chair, Representative Edelson, are you in the bill itself or
I am.
one amendment?
I am in the bill itself.
Okay, can you say this?
Sure. Yep. It's Section 22. So it starts at Section 22, and actually I'm on page 16. Okay. So the one I'm kind of curious about, it looks like you're just restructuring some of where things are, but on 16.24 you strike the relationship of the alleged perpetrator to the alleged victim. I guess I'm just curious in terms of some of the changes that were done here and like what was the thought process behind it.
Ms. Hamilton? I think we need to clarify if that's still in the bill.
Well, okay. All right. Let me see. Let me look.
Okay. Madam Chair, Representative Edelson, this is still a requirement. It just moved up farther in the language.
Yeah, okay. Yep, I see it at 16.7.
Representative Edelson?
Yeah, I just want to make sure all of, because some of the other things are really important too. The names of the persons involved, including but not limited to the perpetrators, alleged victims, and witnesses. I just want to, I see that there, I guess I'm just curious why striking and then putting it back in. I'm so confused with why this was done.
Ms. Hamilton? I just want to point out where we are in the DE amendment. We're page 15, and it's 15.10 through 15.17.
And we can connect offline. I was just curious. I mean, it looks like it's stricken and then put in a different place, and so I'll speak with her after this. Thank you so much.
Okay, Representative Wilson. Further discussion? There being no further discussion, the chair renews her motion that House File 2305, as amended, be recommended for placement on the General Register. All in favor, say aye. Aye. Opposed? The motion prevails. House File 2305 as amended is recommended for placement on the General Register.
Thank you very much, members.
Thank you, Representative May. Representative Pearson, I understand you're going to present Bill 2397 for Representative Pryor.
Thank you, Madam Chair.
The chair moves that House File 23.
I can move that.
Excuse me.
That's all right.
Representative Pearson.
Yep, I'll move that the House File 2397 be recommended for placement on the general register.
We have the bill before the committee. Representative Pryor, please present your bill. Pearson. Starts with a P.
She and I look a lot alike.
Apologies, Representative Pearson.
All right. Easy to confuse us. She'll be deeply offended by that. I apologize. Wherever. All right. Yeah, House File 2397 is again a department bill. We're looking at children and families in this bill. Mostly technical in nature. Some definitions of terms are in there for clarification, and I have a fantastic testifier who has briefed me on the bill, but I think she can speak more accurately to its nature, and I will turn that over to her.
Outstanding. Please state your name for the record and proceed with your testimony.
Thank you, Madam Chair. Jennifer Sommerfeld from the Department of Human Services. Thank you for the kind words. So this bill has only a few provisions in it right now. They relate to child care assistance. Section 1 and Section 2 make some data public that is not right now in our child care assistance program. It's payment data to providers who receive $100,000 a year or more in payments through the CCAP program, or who've had a negative action taken against them. So this data could be requested of the department, and people could receive the information that they've been seeking in the past through data requests that we have not been able to comply with. Section 3 relates to and I apologize, I left my notes in a different hearing room, relates to a child support provision. This was not actually one that came from the department. This was amended in by Ramsey County and Judiciary. And this is simply a technical fix to the parenting expense adjustment statute to ensure that in certain cases, child support is calculated correctly. And that's limited to cases involving child support established for one parent if the child is living with non-parents, such as a grandmother. Section 4 is regarding lump sum payments for child support. Minnesota has a statute right now that says that for child support arrears, you can collect up to 100% of a lump sum payment that's made to an obligor. That's an exception that we have in Minnesota to the Federal Consumer Credit Protection Act, and we have been notified by the federal government that that is in fact not in compliance with federal law. So this simply makes that change to ensure that the state is compliant with federal law. We did in fact notify employers that they should not do this quite some time ago, but we need to make sure that our state plan and our statute match the guidance that we provided. Section 5 relates to consumer credit reporting statute that was passed in, I believe, 2015. There was a portion of this statute that required that the department report an obligor as paying as agreed if that obligor had started making full arrears payments on child support, plus the full monthly obligation. It requested that report that that person is paying as ordered by the court. The department spent about a year on a project trying to implement that, and we learned from the credit reporting agencies that in fact different states cannot have different reporting standards to ensure that credit reports are reliable nationwide. Section 6 allows the court on motion to transfer child support cases to tribal courts if a tribal 4D child support enforcement collection agency is managing the case. Right now there is no specific authority. This creates a complex problem for families who are having their tribal 4D agencies manage their cases, wherein if they need a modification, the tribal agency has to fill out paperwork, move that to the county, through the district court, and then back to the tribe. And this just simplifies that process. And that is the bill.
Is there anyone else who would like to testify for or against this bill? Representative Pinto.
Thank you, Madam Chair. And Madam Chair, can you confirm, so the plan for this bill is for it to be placed on the general register, is that correct?
That's correct.
Okay, and so then a question for Ms. Sommerfeld, I guess. Ms. Sommerfeld, and I know we've got a lot of different pieces moving places. Can you just remind me, so are sections 1 and 2 relating to child care, are they included in in a bill, and I apologize, I know there's a lot of pieces. Are they included in a bill that will be heard in the Early Childhood Committee?
Madam Chair, Representative Pinto, I believe that is correct. These are part of that program integrity package that is set up there as well. So it's moving in a couple of places.
Okay, good. Thank you, Madam Chair. Yeah, because we'll, so then as long as the Early Childhood Committee will be reviewing those sections at some point, then when the bill is brought up on the floor, then at that point we'll have reviewed it and assessed it. So thank you, Madam Chair. Thank you, Ms. Sommerfeld.
Thank you. Representative New.
Thank you, Madam Chair. And Ms. Summerfield, I'm wondering, you mentioned in your testimony some of the issues that you had regarding some of the data requests. And I'm wondering if you can maybe give some explanation as to how this is going to affect that. You mentioned that this should help actually resolve some of that. I wonder if you can kind of go through that language for me a little bit.
Ms. Summerfeld.
Madam Chair, Representative New. Yes, right now, if somebody were to request payment data on a specific child care center and how much they received in payments, we would not be able to provide that data. It's considered private. So this allows us to provide that data.
Representative New.
Thank you, Madam Chair. So currently, so I assume you're referring to lines 1.19 through 2.17. And so under currently, what data is available and what will this make available now?
Ms. Summerfeld.
Madam Chair, Representative New. Currently, none of this data is available. We're not able to provide payment data to specific centers. So this would allow us, if somebody made a request for the top 10 the top 10 centers that receive payments, we would be able to provide that with the names of the centers. Right now, we are not able to. So this allows us for centers that receive CCAP payments of $100,000 or more, we can release that data upon request. Right now, we cannot release it at all.
Representative New.
Thank you, Madam Chair. And can I ask where that $100,000 number came from? I understand, and I assume that this data is in aggregate. It's not specifically tied to any specific children or families. And so where did that $100,000 number come from?
Ms. Summerfeld.
Madam Chair, Representative New, that it does probably seem like an arbitrary number. We made a decision that $100,000 was probably the lowest we could go to without the payment data, even if it's not stated specifically tied to a child. You might be able to identify a child if you started getting down too far in the payments. And so we are not going to release data that would allow somebody to identify a child in a center as receiving CCAP.
Interesting.
Representative New.
Thank you, Madam Chair. Do you know what is there sort of an average of what a child care center might receive in CCAP funds? I know that there's a wide range of facilities from small in-home daycare to pretty large centers. Do you have any idea on what that looks like and how much on average and how many facilities might be above that $100,000 threshold?
Ms. Summerfeld.
Madam Chair, Representative New, I do not have that data with me today. You are right, the average, there's a large range in what centers receive, and I don't have a count on how many centers right now receive $100,000 or more. I'm not even sure if we had that we could release that data. Oh, you do? Oh, I can call somebody up. I'm sorry. I'm going to phone a friend. I misunderstood her motions before.
Thank you. Please state your name for the record and
Yes.
proceed.
Good morning, Madam Chair, members of the committee. I'm Lori Poseen with the Department of Human Services and the Child Care Assistance Program. I can answer half of that question. There are 350 centers in the latest data that we ran that were paid $100,000 or more of about 1,500 providers paid, center providers paid by CCAP. So that's the proportion. And well, I don't have the exact average of all center payments. I can add that the $100,000 was tied to an infant care, young child, infant or toddler, about $10,000 a year times 10. And usually 10 children or less is our limit for releasing sets of data. So that's how we came up with $100,000.
Wonderful. Thank you.
Representative New.
Thank you, Madam Chair. That was very helpful. I appreciate that.
Further discussion. Representative Pinto.
Thank you, Madam Chair. And I'm now that I'm looking at this language, I'm embarrassed for having asked Ms. Somerville because I'm recognizing actually from Bill that I'm carrying. So sorry about that. And I just want to clarify too. Ms. Somerville referenced that the data becomes available, and thank you to the. I'm glad this is brought forward. Again, I suppose in my bill too, so I'm especially glad. For $100,000, but also if you'll notice lines 2.10 to 2.17, when there's some kind of disqualification or a finding of misconduct, whatever else it is. And so that also enhances that and adds that as well. So I just want to make sure to add that to her point, that it's not just $100,000, but in the alternative, even if it's less than $100,000, but there's one of those findings that it's made, that it's available and made public as well. So, which is good. So thank you so much. Thank you, Madam Chair.
Representative Bonner.
Thank you, Madam Chair. Representative Pearson. So just a quick question. So we talked about, and I'm glad that we have some definite criteria to make sure that we're protecting the identity of individual children on that level. That's a big concern of mine, and thank you for Representative New's questions. She answered actually most of mine. But the question that I have is, because we talked here about it being that threshold over $100,000, we talked a little bit about it being primarily de-identified data or high-level data. Can you explain to me the value of that data and in what circumstances or how that might be useful to someone from the outside? What would be the value of being able to get that data?
Ms. Poseen? Ms. Sommerfeld? Who wants to take that?
Madam Chair, Representative. Let's see, I think there were two parts. You said what, well, speaking to the last, what value? I think it's just to make it available when an inquiry is made. Again, we upon request. So I don't, it depends on what the person is asking for. I guess I can't really speak to the value other than transparency of an aggregate amount. And just to assure you, the aggregate amount is what would be provided. So it would be, on an annualized amount of payments. So for instance, in calendar year 18, XYZ Center was paid $120,000.
Representative Bonner.
That answers.
Thank you for that, Madam Chair. Representative Pearson. So I guess I'm still struggling a little bit in that so we know about how many providers took in $100,000 or more, which I presume based on your formula means they meet the requirements that they have a certain number of students. So, I mean, as far as I can tell, what that's really telling us is that we have 350 providers that have more than X number of students, but that doesn't really give any particular detail. So I guess my question here is, if someone's requesting data, I have to assume they're requesting it for a specific reason and that there's some specific thing that they're looking for. And I'm curious because I'm not sure that this 10,000 foot level of data would necessarily provide that detail. So I guess where I'm headed is, would that really cut down on the number of data requests? Or how does that play out?
Ms. Sommerfeld.
Madam Chair, Representative Bonner. So this is about the lowest level we can go to, I think, as far as what we can provide on a granular basis. I think if we went and provided a lot more, it would start to be problematic for the children in our programs. We receive a lot of requests for information on how many centers receive CCAP and which centers specifically receive CCAP payments. And we are unable to provide any information on which centers do receive CCAP payments and the amount of that. And so this would, in fact, allow us to respond to those data requests with responsive data, if that makes sense.
Representative Bonner.
Sorry, and maybe this is something I can take offline, but I'm still having trouble understanding the value of that disclosure, because as far as I can tell, it's not really giving a whole lot of information. And certainly, just to be clear, I'm okay with the fact that we are not giving more detailed data that speaks to specific students for the protection of those students and those families. So I'm okay with that. I'm just suggesting that here, I guess what I'm getting at is we're allowing this data to be released, which is fine, I guess. It's not, as long as it's not calling out individual folks. But I'm just struggling with what the value of that data is on that level, and why, if this is adding additional burden, I guess is where I'm headed with that.
Ms. Sommerfeld.
Madam Chair, Representative Bonner, I think the added benefit of this is simply to provide more transparency into the CCAP program, which, as I think everybody in the room knows, we've been talking about quite a bit lately. And this is part of the governor's program integrity package. So it's in there to ensure that we have access to data that we need to make sure we are being transparent with the program. There are other programs where providers receive payments where that data is also public if upon request. So it also aligns us with other programs.
Representative Bonner.
Thank you.
Further discussion? Okay.
Well, to that point, I guess I would just also add, I mean, anytime we're having public dollars being paid to private entities, we do want that transparency. I mean, it wouldn't matter here, the actual inverse, that we're making those protections or those exceptions for those payments in facilities that would be receiving less than 100,000, with the exception, as Representative Pinto alluded to, reduce that identifiability of folks in public programs. So just generally speaking, I think this is very good policy that's important, whether we're talking Health and Human Services or an agriculture program or anything across the board. We're always looking to make sure those public dollars are being spent with as much transparency as we can possibly provide.
Thank you, Representative Pearson. There being no further discussion, Representative Pearson renews his motion that House File 2397 be recommended for placement in the General Register. All in favor, say aye. Aye. Opposed? The motion prevails. House File 2397 is recommended for placement on the General Register.
Madam Chair.
Representative Albright.
Madam Chair, I move that the Committee on Health and Human Services Policy issue a subpoena to Carolyn Ham, DHS Inspector General, to appear before the Committee on Health and Human Services Policy on March 20th, 2019, to answer questions regarding Child Care Assistance Program fraud and management of the Child Care Investigations Unit. And Madam Chair, I would ask for a roll call.
Representative Albright, would you like to speak to your motion?
Madam Chair, and thank you for that. We were presented with the Office of Legislative Auditor's report earlier this week, and it was, to say the very least, astonishing. And with regard to that, the Office of the Investigative General, as well as DHS, was front and center to that investigation. And so in light of this committee's jurisdiction over those matters, I think it's incumbent upon not only the OIG, but also DHS to submit to a presentation and submit to questioning before this board, this committee, relevant to the findings that the OLA provided in that report.
Representative Albright, we're going to take a recess for the DFL committee members to discuss the motion. We stand in recess to the call of the chair.